Okay, so for our first presentation, I'm not going to read bios that you can read in the pamphlet, and I do encourage you to go through the program booklet and read about the Kaufmans. They're going to speak to you today about MSA research, about the Natural History Study, the Global MSA Registry. What I will say in introduction is that the Kaufmans have been friends of this organization for a long time. They've done an enormous amount of work for the MSA community in their research and their projects. They're both out of New York University School of Medicine, and Dr. Horacio Kaufman is the Axelrod Chair for the Dysautonomia Research Center and the Dysautonomia Center at NYU. And Dr. Lucy Norcliffe Kaufman is also at the Dysautonomia Foundation. And together they've been doing a great deal of work for MSA. One thing I want to add is that they are the host this year for the MSA International Conference in New York City in March. Now that's for researchers, but that is, I think, an enormous accomplishment for them to bring this to the United States, to bring it to the Big Apple. We're very proud of them and their accomplishments and very grateful for all they've done. So I'm going to turn over the floor to the Kaufmans to tell you about the research and GLOMSAR. Lucy, Horacio.
Good morning. Thank you very much, Cindy, for that introduction. So welcome, and we are quite happy that you are all here. And of course, I want to thank the MSA Coalition for putting this together, particularly Cindy Romer, whom you just heard, and Pam Bauer, Don Kraus, Larry Kellerman, and the rest of the board, that they are doing what is now a tradition, and they are able every year to bring researchers to talk with patients directly and being able to learn more about the disease and specifically how to manage multiple system atrophy. So today you heard you are going to have today and tomorrow a number of experts from Vanderbilt University, which are very, very experienced in the management of multiple system atrophy. And among other subjects you have in the program, you will hear about dysphagia, the management of dysphagia, that is the difficulty swallowing, physical and occupational therapy, treatment options for bladder problems, music therapy, some other interesting issues which are the fall in blood pressure that we call neurogenic orthostatic hypotension, and also speech and communication strategy. So you will hear about all these from big experts, and you'll have 2 days to do that. So I want to very briefly tell you a few things. Number one, what are our shared goals? What do we want to do, researchers and the whole MSA clinical and research community, together with the MSA Coalition? Our shared goal, of course, is to cure MSA or even prevent it, eventually prevent it. Now, in the meantime, until we can achieve the goal that we all want, of course, what we want is to be able to provide the best medical care. Now, how can we do that? These 2 goals, to cure MSA and to provide the best medical care, can only be achieved through collaborative research, both basic and clinical. Of course, there's no way to treat problems that we don't recognize or understand. So to treat them, first we have to understand, first recognize the problems, and you are the ones that tell us what the problems are, and then we have to understand those problems. Now, successful research and being able to do these things requires numbers, requires people. Now, as you are aware, only around 15,000 people in the US have multiple system atrophy, and this is a projection. We don't really know if there are 15,000, but that's more or less the number based on some epidemiological data. You all know, I don't have to tell you who MSA affects. It's usually people in their 50s, although occasionally or rarely there are some younger people. Both men and women equally equally. There may be a little more of males affected, but in the big surveys probably is 50-50. And then something important for you to know almost from a political point of view, is that multiple system atrophy is considered an orphan disease. What is an orphan disease? That's a designation that the Food and Drug Administration, the FDA, has for disorders that affect less than 200,000 people in the US. So see, any disease that affects less than 200,000 people is an orphan disease. Now imagine MSA is really orphan, is much less than 200,000, is actually 15,000 at the most. So this poses particular challenges. Orphan diseases have challenges that others don't. So successful research, as I mentioned to you, requires numbers. The only way to do this, to be able to make some progress in MSA, is the cooperation of many medical centers coming together so that they can share clinical data. You would be surprised that in the era of computers and communication, sharing clinical data and being able to put all this data together to get results is quite a difficult task for a number of reasons. Now, we are very lucky that we have been able to set that infrastructure, and is essentially a partnership between the National Institute of Health and the MSA Coalition. So it's federal funding agencies together with patient advocacy group, specifically the MSA Coalition, that we've been able to put together all the infrastructure to share clinical data and genetic data and imaging data from patients with multiple system atrophy from all around the world. And the project is called the Natural History of Synucleinopathies. And I'll show you something about it in a minute. And again, is sponsored by together by the NIH and the MSA Coalition, is part of the Autonomic Disorders Consortium, which is one of the consortia of the Rare Clinical Disease Network, funded by NIH. We have now 16 centers around the world, from Asia to South America to the States and all Western Europe, that are now effectively sharing data on multiple system atrophy. Now, how is this study? I'm not going to bore you with details. I'm just going to tell you that it's just an observational study. There are no direct interventions, although there are other trials that come out from there. But this infrastructure itself includes the clinical visits, with then a number of other tests, from testing smell or olfaction to testing the autonomic nervous system, giving a sample for DNA testing, and a number of other tests. All that patients are then enrolled, and they are followed up at least once a year. All the information go on specific case report forms, and then that is stored in a secure database at NYU, which is secure, anonymous, and has global access, so all the other sites can access that. Now, let me briefly, because Lucy will tell you a little more details about this, let me just go through in a few minutes what I believe are the most relevant recent discoveries in MSA. I would like to tell you something which I believe is the biggest science breakthrough. I'm sure you've been hearing about these things. And what is this science breakthrough? Well, is that multiple system atrophy, similar to Parkinson's disease and other neurological disorders, is actually due to the abnormal accumulation of a protein that is normally produced in the body. Now, for unknown reasons yet, or still, this protein that is called synuclein morphs, for again unknown reasons, into a real killer, morphs into a toxic form that clamps together and injures cells in the brain. Now, this understanding has given us a very clear path to treatments. So this is just a picture of the structure of this protein called synuclein, and as you see, has 140 amino acids. That's like bricks that get together in a big line, and normally is produced in the body. We don't know exactly what it does, but it's a normal protein. Now, I would like to, with a cartoon, try to make you understand, just this is a very simplified version of the basic facts, and this is what they are. You see, proteins are normally produced in the body, and they have a specific structure. In the case of synuclein, they are unfolded. Imagine a long piece of paper that is unfolded. Now, in order to play a biological function, this protein has to be folded with a very specific fashion. You know, I just invented that little plane to see you, to express to you that it has to be almost like an origami. Any protein requires a specific folding to play its biological action. Now, in the case of diseases like MSA or Parkinson's, the folding of the protein is abnormal. So proteins are misfolded. Imagine you have a piece of paper. Instead of making a plane, you actually you just make a particular agents the time that is actually being transported from one to the other. And finally, the third other path is to enhance the clearance. There is a normal way to clear the proteins in the neurons, and what we can do is trying to increase that. So all these strategies include antibodies, specific proteins that will attack another protein, so this could be anti-synuclein antibodies. We can also use small molecules that are called RNA inhibitors or oligomers that prevent the synthesis of synuclein, and those possible clinical trials are in development now. We hope in a few months that we'll be able to start that. That may require intrathecal, meaning directly we'll need a spinal tap to inject these oligomers. And finally, there are also compounds, and there's one in preparation for clinical trials that enhances the clearance of this protein. So one strategy that we are all thinking about is combining these three approaches, reducing the synthesis of the protein, reducing the spread from neuron to neuron, and increasing the clearance. All of them together, we think, will be able to slow the progression, if not to cure, at least to slow the progression of MSA, and perhaps, if we do it early enough, perhaps even prevent the further development. So let me just very briefly tell you a few things about symptomatic treatment. The ones I mentioned to you before are not symptomatic, would be disease-modifying treatments. But we also are working on symptoms. I'm not going to mention all the symptomatic treatments because that's what the Vanderbilt team will do, and they will show you treatments for almost all the complications of MSA. I just want to emphasize one thing which has received somewhat little attention, and is what we call aerodigestive problems in MSA, and you will hear about those things today. So what are these aerodigestive problems? There are two things to consider. One is called stridor. Stridor is a high-pitched noise that people make during inspiration, usually at night, when the vocal cords don't open properly. So recognizing this sound called stridor is very important and is common in MSA because it can indicate it's a difficulty breathing that is potentially treatable. So you will hear about that. I just want to raise your awareness here about stridor. The second issue is dysphagia. Dysphagia is the difficulty swallowing, and it can occur when you can feel that you cannot swallow the food properly, or that it's stuck on your throat, or you have trouble swallowing the pills. That's called dysphagia. And dysphagia, of course, the the biggest danger or the biggest fear is that the difficulty swallowing will result in food going through the wrong pipe. Instead of going through the esophagus, which is the tube that goes from the mouth to the stomach, it can go to the trachea, which is the pipe that takes the air. So I'm just showing you a little cartoon here. Okay, this is the, let's say it's ultra simplified, but I think it's important for you to remember this. This is the normal swallow. That's supposed to be a pill of food. You see it goes from the, you masticate, it goes from the back of the mouth directly to the esophagus. Now, what happens when they are difficult, when it's dysphagia? Again, see that pill or food, when you are swallowing, instead of going to the esophagus, it crosses the epiglottis and go to the trachea, and that can, of course, can produce choking, can produce respiratory infections, bronchial infections, and has a heavy toll on health. So it's important to study it, recognize it early, and treat it. So that's, you will hear about that today. Now, I want to tell you that thinking that there was not enough attention or understanding about these two problems, that last weekend we spent 3 days all together in Bologna, people from all over the world, also sponsored by the University of Bologna, but the MSA Coalition as well, again last weekend, in which people, scientists and physicians from all over the world tried to, or got together to produce a consensus and guidelines on how to screen and diagnose stridor and dysphagia, and how to treat it early, and which are the best ways of treating that. So there was a lot of arguments, a lot of discussion. I think we came out with a very simple document that you will see soon, and that will be useful for doctors all over the world to try to all do the same things. So thank you very much, and what I would like now is to introduce the good Kaufman. I'm just the so-so, who's Lucy, she will tell you some updates on the Global MSA Registry and the Natural History Study. Lucy, take it away.
Thank you, and welcome to Nashville. I'm going to start today and tell you about some of the updates that have happened with the Global MSA Natural History Study and the Global MSA Patient Registry. And I hope you will understand at the end of the talk how those projects come together and how they're helping to support MSA research on an international scale. So, for those of you that don't know, the NIH and the MSA Coalition both jointly sponsor and support the Autonomic Disorders Consortium, which is led by Vanderbilt University and Dr. Italo Biagioni and Dr. Robertson and their teams. And within this Autonomic Disorders Consortium, there are several sites that participate. And at NYU, we're responsible for both the Global MSA Contact Registry called GLOMSA, and you will see in your bags that there's a postcard telling you how you can enroll in the GLOMSA registry. If you haven't already done so, please do so. And this allows us to capture the patient voice. And we also have an international natural history study in which, when you go to participating sites for your office visits, they transmit your clinical data to NYU, where we centralize that information and we use it to study the disease and how people progress over time and the typical features of MSA. I'm going to start by talking about, first of all, the natural history study and letting you know some of the important developments that have come out of that project in the recent year. So the Autonomic Disorders Consortium, although it's expanded now into an international study, really started with 5 core centers within the US. We have Mayo Clinic in Rochester, headed by Philip Lowe and Wolfgang Singer. We have the Vanderbilt team in Nashville, Tennessee. We have intramural NIH with Dr. David Goldstein. We have the Beth Israel team with Dr. Freeman and the NYU team. And all of those sites have been sending their clinical data from patients with MSA that they've encountered in their clinic for the last 8 years. So what we've done, really this year was the time that we were really able to come up with some conclusions about MSA. So let me tell you a little bit about that. We put together the results of 100 patients that presented with low blood pressure standing. And one of the exciting things that came out of that study is that we think that having low blood pressure standing may be the key to detecting MSA in the very early stages before the motor problems, the problems with movement, set in. So now we're closer to premotor diagnosis. We're closer to being able to spot MSA sooner because we know the particular clinical and biomedical profiles that predict which patients have the highest future risk of developing MSA in the future. So let me tell you a little bit about that very briefly. We took 100 patients that had this neurogenic orthostatic hypotension that you're going to hear about extensively over the course of the next 2 days. And we followed those patients for 4 to 5 years. And what we saw is that the patients that also had REM sleep behavior disorder, that's acting out dreams at night, were at the highest risk of developing problems with movement. Of course, problems with movement can be due to a number of different syndromes, can be caused by Parkinson's disease or MSA are the two common ones that we've been looking at. But what we found was that patients that had the combination of orthostatic hypertension and also acting out dreams at night that were in their early 50s and had urinary problems, and those that had a particular autonomic profile showing preserved nerves outside of the body and had a normal sense of smell were the ones that had the highest risk of developing future MSA. So why is this important? Well, let me tell you, it's important for a number of reasons. We know that this protein, alpha-synuclein, that Dr. Kaufman spoke about, is the protein that morphs and spreads throughout the nervous system to progressively injure the cells. And we also know that as we age, even in typical aging, as I'm going to show you in this cartoon, we lose a certain number of nerve cells over time. But in multiple system atrophy, what we see is that process is rapidly accelerated, and there's a much faster decline after between age 40 to 50 in these nerve cells surviving. But it's not until the nerve cells have declined by a certain amount that the clinical features of MSA develop. So we have this period in which you see that there is what we call a prodromal phase. There's a premotor phase. There's a phase in which MSA is emerging, or we think is emerging, but the motor signs have not set in. And this is important because it gives us a window of opportunity. If we can see patients in the clinic that are we think are at high risk of developing future problems with movement and progressive problems of MSA, we have a window of opportunity in which we can interfere with these targeted compounds in which Dr. Kaufman spoke about that are going to reduce the synuclein burden and stop it from spreading to other neurons. Now, that's all well and good. So we can stop the spread of premotor MSA is what we hope. But how does that matter for you in which you have already the motor symptoms? Well, we believe that the same strategies that are going to work for preventing the ongoing accumulation will also help to halt the spread of the protein, even in cases where the movement disorder has set in. So we hope that using these strategies, if we can develop them and we can prove that they work, will also be advantageous at preserving function once somebody has reached the clinical diagnosis of MSA. So finally, one of the things I want to mention is in order for us to make any progress in testing these compounds, in coming up with real strategies to prevent the synuclein spread and to find a cure or really help MSA patients, we need you. And we need you to participate in clinical trials. Clinical trials are important for our progress. It's important that we can test compounds properly so we can find out if those strategies work, and if they don't work, we can go back to the drawing board and find strategies that do work. And without your participation, those new compounds are not going to make it into the clinic. So on that note, I want to tell you about the other study that we have that patients are using. We're using the patient voice to capture some of the other features of MSA, and that is the Global MSA Registry. Here you have in you have a postcard with how to enroll in this registry, and also the link is here, so for those of you online can see it. So why do we have a patient registry for MSA? Well, we thought it was really important to have the patient voice alongside the clinical information that we have in the clinic. We want to know the impact of the illness of MSA and how it affects the lives of the people that live with it. And we want to understand better what matters the most to you. So around a year and a half ago, we started developing a survey, an online e-survey that we wanted to put out to the MSA community and have their voice. So we designed a survey, the MSA e-questionnaire, that captured several different domains, including general well-being, problems with movement, problems with sleep, autonomic problems, which are a key focus of the Autonomic Disorders Consortium, as well as other atypical features, like Dr. Kaufman spoke about, swallowing and stridor. So let me tell you, these are results that just came out. They were analyzed this week, and this is where we stand with the survey. So we had 375 people that responded to the survey and completed it. Of those people that completed the survey, the average age of the MSA patients was 63 years of age. And when I say average, I mean if we take everybody, that's where they kind of fell in the middle. The majority of the respondents were from North America, but we had countries that we had representation from Europe, South and Central America, as well as Australia and the Middle East. So what did we learn from that information? If we took all the respondents from the survey, we noticed something that was particularly striking from us, which is that it took on average 3.5 years from the initial symptom for when a patient for a patient actually reaching this diagnosis of MSA. This to us means the same. We have this 3.5-year window in which we can potentially intervene with these disease-modifying strategies to preserve function. So what was the first problem that people presented with? Well, when we asked people what were the first feature that they first noticed, this is before they actually categorically got the diagnosis of MSA. And you can see that a lot of people had difficulty moving, but there was also a high number of people that had trouble with blood pressure or trouble with urination. And it was a high number of people that the first thing they noticed was acting out dreams. And then we had falling or difficulty with balance was another key feature in which people recognized very early, and there were different other presentations in which we captured. Now, this is particularly striking to us because what it tells us that is in the early phases of MSA, before the motor features are really in place, we see that patients are going to be presenting at different subspecialty clinics. This means that in the early initial phases of MSA, and I'm sure this is your experience too, is that patients will be presenting to movement disorder specialists. They'll be presenting to autonomic specialists or urology specialists. They'll also be presenting in sleep medicine, as well as other different clinics when they're presenting with falls. So for us as a community, what we now realize is that now that we can identify patients that are at high risk of developing MSA, we need to raise awareness about these early features in the different medical subspecialty clinics. So we need to make sure that the sleep doctors are aware that somebody with REM sleep behavior disorder may have a high risk of MSA, and we need to make sure that the other physicians are aware of this. So let me just tell you something else very interesting that we believe has come out of the survey, and that's sleep in MSA. When we put together all the information from this clinical data that came in through our natural history study, and this was work that was pioneered by Dr. Alberto Palma at NYU, we saw that 81% of patients had polysomnography, which is where they had inpatient sleep studies that confirmed the presence of REM sleep behavior disorder, this acting out dreams when sleeping. 81%. And when we went and looked at the survey results, we saw that this was remarkably close. We have 80% of patients with MSA reported acting out their dreams. So this is a common problem in MSA. Despite the fact that this being very common in MSA, we saw that only 40% of the patients had been formally diagnosed with REM sleep behavior disorder. So why is this important? Well, let me tell you, for a number of reasons. Number one, REM sleep behavior disorder is potentially treatable. And number two, REM sleep behavior disorder can, or acting out dreams, can mimic other things like severe sleep apnea. So it's important that we have better recognition of this so that we can make sure that, first of all, it really is REM sleep behavior disorder, and second of all, treat it in the appropriate ways. So on average, and this is the population of MSA patients that responded to the survey, we see that their symptoms began around 6 years ago, on average. But the diagnosis of MSA was reached around 3 years ago, 3.5 years ago. So again, you know, this is consistent with, we have this 3.5 year window in which we could potentially intervene. The vast majority of MSA patients have noticed a noticeable decline in their ability to move within the last 3 months. And if we looked at what we call motor milestones, things that the movement difficulties moving that people experience, we see that 95% of people with MSA after 3.5 years of the diagnosis have difficulty with balance. 81% have muscle stiffness. Around 50% have the position of the head, neck bent forward. 93% have problems with handwriting. Around 60% have tremors in the hands and feet. And what we see that even in these relatively early stages of the disease, we see that 26% require a cane to help support their walking, 44% require a walking frame, and 53% require a wheelchair to move around. So why is this important? You can tell me, look, we already know this. Well, it's important for us as a community to understand this, because defining the rates of progression of affected patients outside of a clinical trial can provide us with really valuable information that helps drug development. If we can understand this better, we can design better trials, which is why we need your voice to be able to tell us how these features are changing over time for you. I'm going to move on now to talk about the non-motor symptoms, the non-movement trouble difficulties that patients with MSA experience commonly. You're going to hear a lot about neurogenic orthostatic hypotension from our colleagues here at Vanderbilt, so I'm not going to dwell on that too much. But one of the things that emerged from the survey, of course, is that urinary problems like urgency, incontinence, frequency, and needing to use a catheter are very common in MSA, and you're going to have workshops today on how to manage those features. We also see that the gastrointestinal problems like constipation, drooling, and diarrhea are extremely common also. So what about these aerodigestive problems that Dr. Kaufman spoke about, the being so important to recognize and treat in patients with MSA? We see that 36%, around 1/3 of patients have this noisy breathing at night. And 63%, almost 2/3 of patients have difficulty swallowing. So we also want to recognize that now, you know, the voice of the patients is telling us, look, these are extremely common, and these are features that the international community of MSA researchers is now much more focused on. So one of the other things I told you that we were interested in is general well-being. And if we look at some of the mental health issues in MSA, which are, you know, they're emerging, people are starting to talk about this, but we really think it's very important. We see that around 38% of patients reported to laughing or crying for no reason. Around 63% said they are more forgetful, and around 58% of patients report feeling depressed. So your voice is clearly important and is telling us features that we should be paying more attention to. So it's clear from us that information, when we trawl through the medical records, when we look at the clinical data, information is missing, like when a symptom started, how quickly it deteriorates, and how patients actually feel about it. Collecting this information from you as a community will help us understand what's important when living with MSA. And this should ultimately translate into better clinical care for the entire MSA population. So we have our work cut out for us. We are working hard, but there is still a lot more to do. And through these collaborative efforts that Dr. Kaufman spoke about, we believe we are making progress in MSA. We're coming together, we're working together, and we believe that we're advancing the field quicker than ever before. But we still need better treatments. We need your involvement in research, be that clinical trials of interventional new drugs that you may try to help your symptoms. We're participating in observational studies like the Natural History Study, where we follow your clinical information from the clinic, or participating in these registry surveys that give us your voice and tell us the features that matter the most to you. And we also need the brightest minds around the world working on MSA and thinking about the problems. So that's why, you know, we're very excited, as Cindy told you, to be bringing an international community of MSA researchers, physicians, basic scientists together in New York City early in March 2018 for the conference dedicated for researchers and clinicians to focus on the features of MSA. Thank you very much.